Good morning. I'm Howard Husick, Senior Fellow here at the American Enterprise Institute, and welcome to our discussion event this morning, Safe Injection Sites in American Cities. Good or bad idea? In April of this year, as of April of this year, the year ending April of this year, more than 100,000 Americans died of a fatal drug overdose. It's the largest single year number ever. It was up almost 30% from the 78,000 deaths in 2018. The figure marks the first time that we exceeded that terrible number, 100,000. And overall overdose deaths have more than doubled since 2015. To combat this tragedy of drug use, at least a dozen American cities have considered experimenting with safe injection sites under the philosophy called harm reduction. But will such sites, already in operation in such cities as Toronto and Amsterdam, actually save lives? Will they have a positive or negative implication for the quality of life in American cities and American society more broadly? These questions, and the core question of whether legal sites for injecting illegal drugs should be permitted by law, are coming to a head. A Philadelphia group seeking to establish a supervised injection site is appealing a court-ordered stay, preventing it from doing so, and awaits a potential signal from the Biden administration as soon as a January 6th court hearing as to what its view of how the law should be interpreted or potentially changed. The past administration's Department of Justice promised to crack down on such proposed sites, citing its interpretation of federal drug laws. But now such cities as Philadelphia, San Francisco, even the entire state of Rhode Island are considering pilot programs focused on SIS, safe injection sites. Should municipalities and states consider these as an alternative model to more punitive enforcement of drug laws? Or would they encourage additional drug use and more overdoses? We're joined this morning by a key activist in this matter, along with two leading researchers, to consider the policy, its legal and cultural implications. On my right in the middle, Rhonda Goldfein has led the AIDS Law Project of Pennsylvania since 2000, directing its work to provide counsel to those suffering from that illness. She's a co-founder and vice president, for our purposes this morning, of Safe House, a public health approach to overdose prevention that seeks to open the nation's first supervised injection site in Philadelphia. She's a member of the board of the American Civil Liberties Union of Pennsylvania, Philadelphia chapter. She's a graduate of the University of Miami and the Shepard Broad Law Center of Nova Southeastern University in Fort Lauderdale. On my far right, David Murray is a senior fellow at the Hudson Institute, where he co-directs the Center for Substance Abuse Policy Research. He previously served as chief scientist and associate deputy director for supply reduction in the federal government's Office of National Drug Control Policy. Before entering government, Dr. Murray was executive director of the Statistical Assessment Service and held academic appointments at Connecticut College and Brown, Brandeis, and Georgetown universities. And to my immediate right, Sharon Larson is the executive director of Mainline Health Center for Population Health Research at the Lackinaw Institute for Medical Research in Philadelphia. She's also the associate dean for research at Thomas Jefferson University College of Population Health. She's a behavioral health scientist. She served in that role at the Federal Substance Abuse and Mental Health Services Administration, which thinks about these issues nationwide. She received her doctorate in sociology from the University of Nebraska. She's a leading researcher and voice in the field and has published a review of the literature on supervised consumption facilities and has modeled and assessed their potential impact for the city of Philadelphia. We want to remind our live stream audience that we're eager to hear your questions. Please submit them in the email listed on your screen below or the hashtag AEI on cities, AEI capital O-N, capital C-I-T-I-E-S. Again, we'll take questions from our virtual attendees in the last 15 minutes of the discussion. I want to start with Rhonda Goldfein because she's putting the idea into maybe action. And so my question to start off, Rhonda, is why do you think this is a good idea as part of a national strategy to mitigate the impact of this drug overdose epidemic. And, well, let's just start with that.
Well, I want to thank you for inviting me to join this panel to discuss this crisis, which is killing Americans by thousands. And there's really no end in sight, which is the segue to why do we think this is important to do. The numbers are staggering. 100,000 overdose deaths in the last 12 months. And I want to add to those numbers that in my city, Philadelphia, in the last 4 years, 3 to 4 people have died every day from overdose. And so we look at what has some promise, what has worked elsewhere, and we compare that to what we're trying now, which is clearly not working.
Well, just when you say worked, what do you mean?
So there are promising reports from sites in Canada, Europe, Australia. They've been in operation for more than 30 years, 100 sites, and there are promising reports from all of those sites that...
Let me, I'm sorry to interrupt again,
please.
But tell me what, and we should have started this way, what is a safe injection site?
Supervised consumption is a really basic idea. Person walks into the site with the drugs they have purchased on their own, and with the intention of using. They had that intention to use whether they walk into our clean, sterile environment or not. They walk into the site, we give them a clean syringe. They consume under the watchful eye of staff, prepared to offer assistance in the event of an overdose. If there is an overdose, we offer Narcan, which is a medication used to reverse overdoses. And then we offer access to healthcare and other treatment services, including recovery services if the participant wants it.
And so success would be fewer overdose deaths.
I think at a very start, at a baseline, surviving that day would be a great start. I think that we have to recognize with the level of mortality that surviving one day is a good thing. And when you talk to families, they're like, one more day would have been great, because if I survive today, I have a chance of surviving tomorrow.
Right, but in the broader picture, if this is to be a pilot program, right, what would be defined for the kind of evaluation purposes that Dr. Larson engages in? What would convince you that this is being successful?
So we look at the reports from all the other places where there are sites, and those reports are promising. They show no fatality in any site. They show decreased fatalities in the vicinity of sites. They report decreased public consumption, decreased public litter, drug-related litter, and no impact on crime. And so I think that if we look at some of those markers...
So crime doesn't go down?
It's not a crime-fighting measure, no.
Okay.
But in fact, there are some recent studies that suggest there may be some improvement in the neighborhood, but we know that research can be looked at through many lenses. I think that what we need to recognize with this initiative is that we are not legally permitted to do this research. We are not legally permitted to open. We have been threatened with arrest if we open. So we have this great idea, hey, shows promise. We think research, more robust research would be great, and yet we're unable to do it.
Right, so two things there. What is the legal obstacle?
So there's part of our regulatory drug scheme is part of actually, the bigger war on drugs is the Controlled Substances Act. And the Controlled Substances Act has a section that prohibits operating drug-involved premises, and premises that are open for the purposes of using, selling, storing, manufacturing drugs. So we were, to kind of go back to the lawsuit just for a moment, as we were talking about in Philadelphia opening, the U.S. attorney sued us in Philadelphia, sought a ruling from the court that our activities would be illegal. We won in the district court. Judge ruled that our purpose was not to use drugs, but that our purpose was to save lives. And the law doesn't prohibit that. We lost at the appeals court in a divided decision 2-1. So that, in my mind, kind of puts the box score at 2 federal judges for, 2 federal judges against. We lost the hearing, a request for a rehearing on banc, for more judges, again, strong dissent supporting supervised consumption.
So this is going up the legal chain right now.
It is.
And where does it stand at this instant?
At this moment, just to step back for a second, we sought review before the U.S. Supreme Court. That review was not accepted. We are back in district court, the original district court where we appeared in before, and we are asserting our religious freedoms claims because as people of faith and conscience,
All right, so you're starting over with a new argument.
It's the same argument that we made before, but we are now pursuing that because our other claims were resolved when the decision was in our favor.
And is this where you expect that the Biden administration may or may not weigh in?
Oh, they'll have to weigh in.
All right.
We have a lawsuit, and so their choices are to look differently about supervised consumption, take the same hard line that the preceding administration took. If they don't weigh in, then we win. That's how lawsuits are.
Right. So the question is, you're calling it a hard line, but if they adhere to the same interpretation that the previous administration did of the Controlled Substances Act. Okay. Let me turn to David Murray. You heard Rhonda's concern about avoiding overdose deaths. You looked at this kind of issue for the whole country at the Office of National Drug Control. Do you find that to be a persuasive argument?
My posture is to resist this development of a safe injection site. I don't think it actually functions the way it's been advocated for. The problems are threefold. I'm going to say first, at the fundamental level of public health, there are some serious challenges here, both about what the actual outcomes are, and even more so with regard to how well we know what we think we know and are claiming about the purported outcomes, the safety thereof, and the net impact on the community and on the user. Are they in fact saving lives? And I think the record is very poor in that regard. Second, if I get time,
elaborate on those points first. You'll have time.
Sure. Second discussion would be the changing drug dynamic itself. What is happening on the streets? What is the future in which the drugs themselves are shaping? And are we actually prepared to forfend and defend the patients themselves who's our greater risk? And are we actually enabling and sustaining high-risk behavior that ultimately will end up costing them their lives? And if not mortality per se, which is the principal metric we've got here, the morbidity that accompanies their continued high-risk behavior. It's a function of the drugs themselves. The mental health, psychological effect, the schizophrenia, the paranoia, the actual psychotic breaks that are part and parcel of multiple drugs of abuse being consumed simultaneously. We have some responses for the opioids per se, Narcan, the naloxone reversal. We have no such tools with regard to the subsequent drugs that are also injected at the same sites at the same time.
You're talking
cocaine,
about the fentanyl
methamphetamine,
epidemic.
and yes, and the fentanyl we can respond to, which is one of the opioids. Nonetheless, we find we don't have those tools, and these people are at high risk from the morbidities. But the problem here is methodologically. This is an illicit behavior. We can only do observational studies. It's very difficult to recruit the gold standard of a public health or medical intervention, which would be some kind of effort to have a randomized control trial. That's not available to us here. These are observational studies, and they involve a population that has a tendency to be problematic in their securities and their responsibilities, difficult to trace, and they have very high attrition from these sample populations. The people most at risk and most likely to have adverse outcomes filter away from the participation in the sites. Critical issue here is people don't just inject the drugs at the sites. There's a strong tendency for the study population to continue injecting multiple times a day at various sites, including through the illicit black market back on the streets. They may not overdose in the site facility itself because they received the Narcan reversal, but they do overdose in the aggregate because they continue to engage in the high-risk behavior. And the data are actually fairly troubling in this regard. Two instances. The District of Columbia, which does not operate such a site but has liberalized its drug laws, had a 200% increase in the year 2019 to 2020 in the distribution of Narcan naloxone. And yet the overdose rates in that year increased 46%. The aggregate impact was counterproductive, adverse. And even more striking, this facility that has had the longest run for over 2 decades now is in Vancouver. I've studied it, I've been there, I've been to Amsterdam, I've seen these sites in operation. They had, in the last year, the highest participation rate in the facility itself they've ever seen. They had record doses of Narcan, naloxone reversal offered, and record doses of buprenorphine medication-assisted therapy offered. And the net result in that single year was a doubling to yet a new record in the number of overdose deaths. So the study population is indicative of a kind of risk factor because they're still engaging and we're enabling and sustaining high-risk injection behavior with drugs that are not susceptible to overdose reversal. And they're in contexts where the people who need these drugs and continue to use them multiple times a day don't prefer to do them. It becomes simply a place where they continue to inject drugs in addition to their other sites and exposures,
right. And so some of the examples
market.
that Rhonda mentioned, for instance, the studies showed there are fewer syringes on the street. It's a big issue in New York right now, Washington Square Park, littered with syringes, neighbors up in arms. She says there are fewer syringes on the street in studied areas, which would indicate that there's less injection going on in the surrounding area. You don't find that convincing?
Well, it's problematic because you still find an extraordinary number of syringes, and because these other injections are not done in safe circumstances, and people continue to avail themselves of the illicit black market context. Moreover, these studies are absolutely dependent on self-reports of behavior. Did they increase their drug use? Did they increase the frequency? Did they increase their irresponsible behavior? Well, no, they say. And we don't have no objective measures of the actual medical impact,
right.
Other than the overdose deaths themselves, which continue to skyrocket.
And so the fact that some people, because the context is constantly changing, drugs are being distributed, more drugs are available, it's a shifting terrain. The fact that some individuals will go to those sites and have their lives saved is not enough, in your opinion.
To have a life saved, I believe, really requires that we alter or prevail them of the change in the deadly behavior of injecting the substances themselves. The substances are poisonous to them. Whether they have a mortality episode through respiratory depression, if it happens to be an opioid, on a particular occasion of use, is not a guarantee that you have saved a life. Anymore, if someone falls in the water in a river and you rescue them and then you leave them back in the river again, have you actually saved a life for that moment? And that is a goal, and it's a worthy goal. Naloxone is a tool, but it is not a strategy, and it is not a way to actually reduce, by the evidence, the toll of overdose and the loss of a generation.
Okay, well, that is a great time to bring in Sharon Larson, who is an evaluation researcher. And so we have dueling evaluations here. And how would you, rather than just, you're welcome to sort out their different assertions, but how would you think about, if this is going to be a pilot program, right, how would you think about evaluating whether it was successful or not successful? What would convince you that it was successful? What would concern you that might make you think it should be discontinued?
It's a great question, and one I've spent a fair amount of time thinking about since we completed a study in Philadelphia in 2017 to try to figure out what would be the right outcomes to be thinking about. So I think, we're right here. We don't have a denominator. So understanding...
Talk about that for the uninitiated.
Okay, so we don't know how many people out there are sort of eligible to be a part of a study. And so amongst those who do end up in a safe injection site of some kind, they represent a numerator, a number of people who are availing themselves of the site. We don't know how many people didn't. Some work.
Drug users.
Exactly. And in some of the anecdotal as well as beginnings of looking at some of this, for example, the on-site setting in Canada, have begun to try and figure out what does the cohort look like. But that's the best we can do. And some of that is the nature of people who are seeking services versus not. It's about trust, I would say, and how willing they are to share information. So that's at the individual level. And I think it's really important to consider how do we figure out whether this is working, who it's working for, who is not availing themselves of these kinds of services if we have them available. And I think figuring out what the right outcomes are to begin the pilot study is important. So we have to...
Before you begin a pilot study, then, you would want these methodological questions decided.
I absolutely would. So, how many people... I don't think engaging an accounting function is the right strategy.
What do you mean by that?
How many people came through the door? Because we don't know how many people didn't come through the door. We have a bit of a guesstimate around that. For example, in Philadelphia, are we thinking that we have about 250,000 illicit drug users?
250,000.
I think that's a number that I've heard recently. So it's...
What's the population of Philadelphia? It's under 2 million.
Right.
It's a very large percentage.
It's a very large percentage. Are all of those folks using injectable drugs? I don't think that we're suggesting that all of those people are using injectable drugs, but a fair number of them will be.
So you're not giving a yes or no in the legal concern that's ongoing right now. You're saying that if this safe injection site were to proceed, you would not want it to open its doors because if it's to be a functioning pilot, a lot of methodological issues and how to measure success or failure have to be decided first.
So I have a couple of sayings that I'm sort of known for. One is there's never again a day one after you've started something. From an evaluation perspective, if you don't have that good foundation for this is the data we want to collect, these are the stories that we want to tell with that data, if you don't sort of think that through at the beginning or even the pre-beginning in that pre-implementation phase, then it's going to be very difficult to answer questions about what happened as you move forward. So I think that's important. I think the other thing is to think about what other kinds of things do we want to know about the impact of a safe injection site, because there are communities involved. And so thinking through, in our study for this city, we thought about, what is an average ambulance cost? And how is that associated with the number of calls that an ambulance gets to respond to an overdose?
Right, so could this safe injection site reduce city financial costs?
Exactly.
But when you say there's community involved, there's also a site, a community site. And what's your sense of how communities welcome or not welcome this?
Well, I think the literature suggests that cities, particular communities within cities, it's really difficult to think about a city because cities are
the
big.
neighborhood around the site.
But the neighborhood around the site, there is still that not in my backyard sort of thinking, the NIMBY movement.
And that makes it a pejorative, but what motivates their concern?
Well, they're concerned about the very things that have been talked about here. Is there an increasing crime rate associated with citing one of these? I think it's very difficult to know that because we have no sanctioned facilities in the United States, but the literature suggests that in other places with different policies and legislation and regulations, I think there's some evidence that there is no increase in crime. But we could measure that.
Right, and no increase doesn't mean, there's a sense, and this relates to the drug legalization movement, all of that, that if you make things safer, that crime would go down, but you're saying it doesn't go down.
I'm saying we don't know the answer to that.
But we haven't seen it go down elsewhere.
Right. I think The things like needles on the street, people injecting publicly. I think there's some evidence that that has declined in communities outside of the United States because, again, we have no sanctioned facilities here to even test some of these hypotheses that we might have about what would happen in a community where this is located. I think we also have to think about some of the other costs associated with injection drug use. We have skin infections. And this was actually something I knew nothing about before we conducted our study for the city of Philadelphia. But the use of dirty needles, the use of jagged needles, using the same needle over and over again.
So that leads to emergency room visits.
Increases, right. And the average hospital stay for someone who has a skin infection associated with using a dirty needle over and over again is about 6 days. So you can imagine the cost, and if the city is responsible for that, that's a huge cost.
Right, so we want to see those go down. But that gets us to the core question that David and I think Sharon have tossed back to you, Rhonda, which is, if we're going to undertake this as a pilot, how would we know if it's successful, and what would make it not successful?
So I think we need to back up for a moment. If researchers are at risk of substantial federal penalty, we can't begin to have the conversation. And so an idea is, let us begin this conversation, let us open the sites, let us begin to save lives, and we will engage in the robust research that we all agree would be important to add to this discussion.
David is
Could I just
leaning in
not
quickly.
suggest that we could look to Vancouver, and they're enabled to have the research, and it turned out to be as challenging and problematic as we expected. As a matter of fact,
and
Sydney and other places.
do you agree with anything he said about Vancouver?
I think that to suggest that there are more overdoses when there's a proliferation of fentanyl into the drug supply, we can't tag what's the problem. I think it's a with all due respect, a leap to suggest that because there are more supervised consumption sites, there are more people using drugs and there are more overdoses.
Is that what you're saying, David?
That's not the argument. We do not find that we can prove that the presence of a site enhances greater drug use, so we worry that we do erode the norms and the incentives for getting into treatment and getting help, which is an alternative we should be resorting to. But we do know that the data of overdose doubling is not consistent with a positive effect.
Well, it didn't decrease it anyhow, we can say. But I still want to press you, Rhonda, on if we're going to open the doors and we're going to be rigorous the way Sharon wants us to be, what should we measure? Should we just measure overdose deaths? Should we? How are we going to judge whether this thing is going to work?
I think that sitting here today, we won't come up with a definitive list of metrics that will say this has been a success. I think what we need to come up with is, ideally, an agreement that we need to push forward on this research and saving lives. Because we know now what we have now isn't working. We see increased overdose deaths, we see destroyed neighborhoods. We need to do something different. What we're trying now isn't working, and to say other research is inconclusive, okay, but that's not a reason not to continue to try. And we have been here before with with syringe exchanges. 30 years ago, Mayor Ed Rendell signed an executive order.
Former Philadelphia mayor.
Twice Philadelphia mayor, twice Philadelphia DA, twice Pennsylvania governor. Board member of Safe House. He signed an executive order 30 years ago allowing Prevention Point Philadelphia to open. And they opened, and that was day one. And then they began to collect research. And so would we like to be able to have our metrics in order before we open? Sure, but we're in a public health crisis. And so we know from research about Prevention Point, researchers at George Washington University found that from 1993 to 2002, Prevention Point in distribution of clean syringes averted 10,000 cases of HIV infection, which was a cost savings of $182 million. And if we factor in the average lifetime HIV cost of care data, that was calculated to be $1.8 billion. These things work. And so the idea that we'll develop the perfect study and then we'll open the doors, what about the people we're losing every day? Do we say to them, well, you die, we'll say to the families, okay, well, your person died, but we have down the road developed so much better research.
Or we're worried that we make things worse for other people. There's a way to phrase these questions in different ways.
Certainly.
But
Right.
David, what would convince you to allow those doors to open? I'm going to just say this. Canada is not the United States. It's a pleasant place, and Vancouver's a beautiful city, but it's not Philadelphia. So we can't take that as our only data point.
Well, there have been evaluations of Safe House as it was operating unsanctioned, and many of the same dimensions surfaced there very quickly in terms of the unreliability of our knowledge as to whether or not this worked. Nonetheless, because we have alternatives in policy that I think are superior. Let me give you a short example here. We talk about sometimes a referral to treatment that may come out of engagement with a facility. We wish that were so. And that would be convincing if we had good data showing that people actually get into treatment and recovery from their exposure. We don't see that, in fact. What we see is sometimes someone gets detoxed. And at Insight in Vancouver, a proposal is on the works now to provide diluted, very powerful opioid hydromorphone in vending machines. Now, how does that give you a referral into treatment with a physician and recovery? It doesn't. Here's what I think is
Well, that's an
important.
argument against drug legalization, not against safe injection sites.
This is an argument against the notion that we are getting success. You asked me what would I regard as a compelling argument, and I would say if I saw referrals to treatment and a change in high-risk behavior, but we do not see this. And yet we have policy alternatives, and treatment should be the foremost of them in terms of getting people in high risk to alter the high-risk behavior, and we disincentivize that by making drugs more available and greater supply, and by disattending to the risk of the person engaging therein. You turn the police away, greater drugs flow, dealers show up. Okay, here's the critical issue also. We are not addressing drug supply.
Well, let's put that. I'm going to bracket drug supply, because there's certainly flooding in. But you're arguing here that there's a signaling effect, as the economists say.
There is.
Right? That if you open a safe injection site, that is signaling that society is tolerant of drug use. Am I putting words in your mouth?
We could see a potential erosion of deterrence, and a norm is set that a generation emerges in the midst of where suddenly this is acceptable, and we end up with a San Francisco street where no one really knows what to do and they avert their eyes, and that's potential. But I don't think we can bracket the supply issue.
Okay.
Because this is an
Quickly.
alternative. All right, here's the critical issue. A few years ago, there were around 3,000 pounds of fentanyl coming into the United States being seized, and it became 5,000 pounds. In this last year, it's 12,000 pounds. It's enough to create mortality for almost every citizen in the United States. And we have decided to abandon the border. Now, how can we possibly say we're effecting a strategy of saving lives when we enable the presence of the deadliest poison in vastly great amounts flooding through our streets, and the drug situation
Right, and
is changing?
that's an issue at the federal level. But if you're the mayor of Philadelphia, you're looking at 250,000 drug users, and how do I keep ambulances off the street? I want to do something right now. But let me go back, Sharon, to this question, which we can't seem to get a handle on, which is it really that complicated? And Rhonda's saying, well, we got to open the doors and then study it. We can't defer that even until we have an evaluation strategy. Is it that hard to come up with just an evaluation strategy so that on day one we're ready to study things?
I think we can start. While I hate counting functions, we can use a counting function. We can count how many people receive services, and this has been done in Canada, in Australia, all over the place. I want to quickly, though, just mention, in Australia, what they found is that when they opened up one of these sites that they call something different, I don't remember the name of it, but they saw 15,000 people in a year. And of those, 10,000 had never involved themselves in health services prior to coming through that threshold and getting involved with a safe injection setting. So what does that mean? Well, I think everyone here would say it's unlikely that someone who comes through the door the first time is going to be ready to go to treatment. The second time they may not be ready. But these are folks who had never had an opportunity to have a screening and referral to treatment. 2/3 of that sample had never received care. So I think we start with something. We start with trying to gather information. We have to build trust with these people. It's no different than building trust in data collection with a population of African American men who truly believe that we're out to mistreat them in the healthcare system. I think the same is true in this kind of setting. So we have to start by collecting that information that is going to give us insight about how to build the study.
Right, so I'm going to circle back to the treatment question, to the evaluation question, but in effect we have a debate here between can we help a population that presents itself at the door of a safe injection site, or would we risk doing harm, not helping them in the long run, and doing harm to the broader population through the implicit intent of that policy? It's a very hard question, especially if you're the mayor right now. But I still want to know, do you measure overdose deaths? Is that the key question? If overdose deaths don't go down, does that mean it's a failure? Do you measure overdose deaths among people who walk in the door? What the heck do you measure to know whether this experimental program is a success?
I think the answer is yes.
How about successful completion of a treatment episode?
There you go.
And a life of risk reduction. And that has not, in fact, been gathered.
And
So we have to go with the longer term, longitudinal, as the social scientists say.
I'd settle for supply reduction that eliminates the poisons.
Well, okay, but we're not in that
Because
world.
behavior changes. But are we even trying? We're being counterproductive.
Well,
and I think this
I don't think there's going to be a lot of disagreement that people on this panel would like fewer drugs to come into the country.
But then why are we enabling safe injection facilities that enable the presence of the drug under state sanction?
Rhonda's leading in.
So I certainly agree with David that I'm not in favor of illegally manufactured fentanyl that's contaminating the drug supply. So I agree.
Right.
I also wanted to be clear that when what we envision on day one is data collection. Right? It may not be the definitive matrix that we have on day
I want to
one.
know what to collect.
So David referenced the unsanctioned site that's opened. There's several reports out from that site about what they've collected and what that has shown. And I think that if we try to focus on it's only a success if you have a long, you go on to live a long, healthy, and productive life. Let's look at another setting where people are in extremes and you want to try to save them that day, like an emergency department. I walk into the emergency department. You saved my life. Sorry. You're not going to suggest, well, what are the other activities that you've done that have put you into cardiac arrest? Do you commit to not doing those in the future?
Well, we do that. Sharon was a high-ranking official at the Substance Abuse and Mental Health Administration, agency?
Services Administration.
Services Administration, that's a long acronym.
It is.
But when people come in mental health distress, we don't say, well, we got you off the street. We say, we're trying to refer you to mental health services, right?
And we are moving in a direction in terms of data collection across the spectrum of healthcare, where we're trying to capture that population health level information, psychosocial information. So, doing depression screenings, doing screenings for anxiety. We certainly try to screen for drugs in healthcare systems, drug use history. I think what I'm hearing from David is that, yes, we do need to better understand how people move into drug-using behavior, and we need to figure out where the intervention point is long before they get to a point where they need a safe injection site. But we're going to have to figure out how to collect data that allows us to model that. So with our folks who go to a safe injection site, how much information will they tolerate us collecting? Mm-hmm. It may not be a lot day one. It may not be much more on day two.
So there's a gathering of what the social sciences call observations. Even that's hard to do. So this is a real methodological challenge. And I think what Rhonda is saying, and we see the polarity here, right? The poles of the discussion. Rhonda's saying, if somebody uses drugs and doesn't die, that's success. They didn't die today. That's why I want to measure success. And David is saying, well, no, if that's not enough, that's necessary but not sufficient. We want to move to some kind of intervention that will lead them to a more productive life. And he's not sure that the safe injection site is the right kind of intervention to start that long-term improvement. Am I summarizing this right, David?
Yes, and I think just a piece of data. Fairfax County has, again, a huge increase in overdose deaths, and they pointed out that 75% of the people who died this last year in Fairfax County had had multiple previous overdose experiences where they'd been revived and returned to the street.
Right.
So the aggregate was the feature where we lost the lives. Maybe not today, but within the space of time that we create an aggregate risk that is enhanced and a generation emerges in that context with a changing population. Fentanyl was the big hit to everybody. No one was ready for that. I know there are synthetic opioid analogs, 16 of them at most recent count as of 2019, that are fentanyl-like but not fentanyl. So if you're doing test strips for protection, a contaminated supply, many of them don't even build the same way out of fentanyl as a underground kind of chemist.
Does that mean they would be resistant to the reversal?
They are very much resistant and problematic to have a Narcan standard dose to someone who's deeply embedded with fentanyl, but the new versions of the drugs that are opioid-like and produce respiratory depression, there's an entirely new generation of designer drugs coming onto the street.
That raises a fascinating question for Rhonda, who is an attorney as well as an advocate here in this context. You said that the study showed that nobody had died. What if somebody does die of an overdose at the safe injection site? What would the legal situation surrounding that be?
Well, the best predictor of what will happen is what has happened.
I know, but I'm going with a hypothetical.
So I think that there are too many variables to say what would be the circumstances behind a death that would allow us to start tagging liability. If we want to think about liability, what's the liability for not doing enough today? I mean, I agree with David's compelling arguments for longer-term research. I agree with the problems with our tainted drug supply. But people are dying today.
You've made that point, but I want to know, if somebody walks into the safe injection site, injects drugs that they have purchased illegally, and they die, and the police are called, what happens next?
Well, it will be fact dependent. I mean, it's too broad of a question to ask.
Okay.
And I think that it is as legitimate of a question to say, if on my watch, I'm allowing people to die in the streets between parked cars because we haven't opened a door to have them come in and to give them a clean syringe and give them the Narcan that federal agencies encourage us to distribute. Where's my liability for that?
We have a societal liability, there's no doubt, but I'm just contemplating that you must have contemplated from a legal point of view, there must be some fine print about what happens if somebody dies.
I think all of these factors are in consideration, and we come back to the same point. What we're doing now isn't working, and it hasn't been working for many years. We have these skyrocketing fatal overdose rates, and we need to do something better.
Howard, could I just make one last comment?
One quick point, because I'm going to bring in our questions from our audience.
Maybe
and I want to remind the audience, as Rhonda has pointed out, at a January 6th court hearing?
It's not a court hearing, that the government must file their response to our latest complaint on January 5th.
And your complaint is about the interpretation of the Controlled Substances Act, which is precluding you from opening your safe injection site?
It's a little bit more nuanced than that, but the answer will require a response from the Biden administration on where they stand on supervised consumption.
And that will happen on January 6th?
5th, I believe it's the 5th.
Okay. All right, I got January 6th in mind. All right,
Here's my
David,
last
real
point.
quick.
Because the word liability came in, I asked finally a question that if we are to move in this direction, where there's sanctioned, state-approved distribution, availability, and provision of services with regard to the injection of dangerous and fatal, in many instances, drugs. Question is, what happens to the notion of the citizen and the state? Who are these people that we are now sustaining by official legal imprimatur? Are they disabled? Can they drive a school bus? Can they fly an airplane? Can they, in fact, have standing and rights? Or do they find that they are now, as was said to me by a physician in Amsterdam when I visited one of their early sites, we have them on a leash. And if they misbehave, we withhold their heroin. Is that a relationship between a libertarian and a citizen and a state where we find people enthralled to the state itself by virtue of drug addiction?
Right, well, and of
That's
course,
not permissible.
that hasn't been proposed. You're saying that could happen.
It is happening now.
But that gets you to drug testing in the workplace and other kind of issues which are beyond our scope here. I'm going to bring in, we have a whole bunch of questions here. And this first one is for you, David.
Oh, okay.
How should we compassionately
I knew it.
deal with these high-risk drug users? Couldn't this just be another tool in the toolbox that helps reduce overdoses?
If it's not counterproductive in terms of its aggregate impact. The issue is, are we in fact adversely making things worse? And the circumstance actually is deteriorating because of our own actions. First, do no harm. My suspicion and fear is that we are sustaining and enabling when we could be intervening and changing high-risk behavior.
Okay, I'll take the key word there, aggregate, right? Some individual, we don't know, could be saved today, Rhonda's point, but you're saying in the aggregate there may be, it may be counterproductive.
We are bargaining with a cancer rather than addressing it.
Rhonda, this is for you. With your lawyer's hat on, talk about the differences, if there are any, between state and city pilot programs. Do states have more authorities, and this comes up because Rhode Island is considering this, to set this sort of policy?
I don't know if it's a question of more authority. I think it's the will of the vicinity.
Could they do it legally?
There's always the federal challenge. So even Rhode Island, which I applaud for their state change, they're still looking at the federal threat.
So the answer is there's not a difference. And this is the third question, what are the tea leaves on where the Biden administration, has there been any early signaling about what anything, for instance, that officials have published before they got in the administration that might indicate where they might be heading?
Well, the National Institutes of Health recently released a report calling for more rigorous research and evaluation and saying, quote, that it may be prudent to consider the American Medical Association's recommendation of developing and implementing pilot programs in the United States designed, monitored, and evaluated to generate locality-relevant data to inform policymakers. So I'm going to say yes, there has.
So you would, if as somebody who follows NIH pronouncements, you would interpret that as positive for Rhonda's case?
Go forth and evaluate and do research.
Right.
Well, the administration has also prioritized harm reduction strategies, which would be a kind of signal of a greater willingness to embrace this direction, whether that's for good or ill. I'm suspicious, but concerned.
Well, can I just say, I don't think anybody expects that the safe injection site is the complete and total answer to resolving drug use in the United States. I think it is, in fact, one thing in the toolbox that we can use in order to lead to reduced loss of life.
Well, I'm just going to read something real quickly from Jeffrey Singer, who is a physician associated with the Cato Institute as a senior fellow. I think we've talked about this. He's talking about the Vancouver study. Results have been encouraging, as Ron had said, per her way of looking at things. He does note, though, that Health Canada has continued to approve safe injection sites across the country. and we hadn't heard this before, since January 1st, 2016, the number of supervised consumption sites operating in Canada has increased from 1 to 38. Are you aware of this, Sharon? And have those been evaluated?
I was not aware of the number of sites that had been increased, but we certainly in Philadelphia, in visits back and forth with the on-site folks, knew that they were moving toward increasing the number of sites.
And I have visited several sites in Canada, in Toronto, in Vancouver, where Insight is. So Health Canada is looking at their data and saying, continue on.
Couldn't this be an occasion, though, for NIH to scratch its itch for more research by evaluating, and this is something David suggested, the Canadian experience? Or is that so orthogonal, different from the U.S. that it's not relevant? Sharon?
I do think that there are some important regulatory, policy, and perhaps cultural differences in the way that we think about healthcare here in the United States and how people might respond to the location of a safe injection site. I wanted to say one other thing, and that is it's important, if you're going to do this, it does become important once we sort of figure out that it's working or it's not working. If it's working, then we need more sites because we know from the research that location matters. Rhonda sent us all the study recently conducted by Ware and colleagues that...
That's a person, Ware.
Yes.
Right.
Okay.
Who found that the further out you get by quarter mile after quarter mile after quarter mile, there's a drop in the number of people visiting a safe injection site according to their projections.
All right, so that's very interesting. So it's an extremely localized impact. And that gets us back to the citing issue, which we haven't talked about very much. And I gather that Philadelphians have not been eager to embrace your site, Rhonda.
I think that's an overstatement. I think that there were some neighborhoods in Philadelphia that were loud about their objections to the site. But when we had originally talked about opening up a site, we received about 300 points of contact, through email or text or phone calls. And we had the outliers on either side. Some people were saying, why isn't it open now? What's wrong with you? Move quicker, move more quickly. On this side was, you should die along with the people on the site. But in the middle, in the solid middle, people say, I don't know if this will work, but I know what's happening now isn't working. We need to look at this more broadly.
If you were hired as a consultant by neighborhood group South Philadelphia, what would you advise them to demand, let's say that, to demand in order that this site be acceptable?
I don't have an answer for you on that. I think as a community member,
yes, put yourself in those shoes.
I would want to make sure that my children were going to be safe and unimpacted by the locating of the facility.
So not near a school.
It shouldn't be near a school, and maybe it's going to be, we're going to see a decline in the number of syringes that are being left in the neighborhood, and we're going to see a reduction in the number of people who are injecting in public because there is maybe a safe injection site located. I think there are compelling arguments for locating these facilities in communities. If those good things happen, crime rates at least don't go up, and maybe they go down. We don't know. But I think that those are the kinds of things as an informed citizen, I would want to make sure that those kinds of things are being evaluated over time and that there are strategies in place to deal with any adverse effects.
So you don't want
that might
children
appear.
being bothered by addicts
Exactly.
on the street. When the FDA makes its decision about whether to permit drugs to be judged safe and effective, sometimes the trials are so positive that they say, we're going to stop the trial. We're going to go forward. right? But sometimes they could be so negative that they stop the trial too, right? So, David, I'm going to ask you, even though Rhonda's really excited about this question, I'm going to ask you, what would you be looking for as a community member or an advisor to a community group that would convince you that you got to stop this right now?
The case is not made based on the data we have. The case is not made that they work as advertised. Advocates are everywhere pushing for more and increasing the flow, and I believe that this will lead to greater tragedy rather than actual saving of lives in the aggregate.
Right,
I would
so
look for
you're back to the
recovery.
aggregate. It's not like there's going to be some type
No,
of incident.
let me finish what I will say, and I won't use the word aggregate. Let us say that this is your sister or your child or your loved one, and they are in such a circumstance, and there is the prospect of getting them into recovery, of bringing them home, of restoring them, and that should be our first policy objective, not sustaining and enabling them, and that likewise running the risk that we are inflaming a wider context of even more victims to come. That's what I fear that we are facing as a choice, and the case is not made that these work as advertised.
All right, I'm going to drill down on this with Rhonda. Is there anything that could happen that would convince you that you don't want to go forward after 6 months? Anything?
It's a little bit hard to talk about the range of possibilities in the universe. And so what I would prefer to say is, let us begin on day one, let us begin with collecting information, and let us evaluate where we are in 6 months.
What about you, Sharon? Is there anything that would convince you? I mean, anything. Pro or con? Anything in the near term would say yes, no.
Well, if we're able to use that sort of FDA rigorous
Yes.
thinking about a clinical trial and framing this as a clinical trial and making sure that we're very thoughtful about what the outcomes are of interest. How many lives were saved during that time? How many people were referred to treatment and actually received treatment? I want to just say that this is the part that probably concerns me more than anything else, and that is we don't have enough providers.
Treatment providers.
Treatment providers.
Right, so we talk about treatment as if.
Exactly.
And I think that that's the segue to why what we're trying isn't working. You know, the current policy objective is to always bring our sister, brother, parent home to get them into recovery and save their lives. But that's not what's happening. And so we have to look at what can work. And I did want to respond to this idea of a compassionate use in clinical trials. So yeah, we may start the trial, we may stop the trial based on the data, but we also have, as part of our regulatory system, we allow people to try, people with serious diseases to try drugs or medical devices that have not been proven safe and effective. People with cancer, for example, have access to unapproved drugs when the current treatment doesn't work. And we allow this compassionate use because it will save lives. And so I want to encourage us all to think a little bit more broadly. Is it something about people who use drugs that we feel they're not worthy of the same compassion?
Interesting analogy. I'm going to bring in a comment here, and I think it's going to be almost the concluding comment. This comes from an audience member. Harm reduction is based upon the realistic understanding that we will never have a drug-free society. The idea is to make risky lifestyle decisions less risky. It is non-judgmental. We doctors, and I'm assuming this commenter is a doctor, engage in harm reduction when we prescribe statin drugs and antihypertensives to our patients who continue to engage in risky lifestyle choices leading to cardiovascular disease. And so that brings us really to the broadest possible conclusion to our discussion, which is how can we mitigate this epidemic of drug use in the first place? And everything we've discussed here is a subset of that larger and much more vexing question in which the plan is somewhat indeterminate right now. And Rhonda and the other SIS, Safe Injection Site advocates, are saying, let's put this in as at least some kind of trial. And we've heard a pretty robust discussion on all sides of that today, and I want to thank Sharon Larson, Rhonda Goldfein, David Murray for engaging
Thank you,
in
sir.
this really good discussion. Thank you very much, and thanks to our audience for joining us.
Appreciate doing it.
Thank you.